All right, so I'm sitting here with Ahmed Marmoush. I was going to throw the R in. There is an R, but my Texas sensibility, I want to throw it in there. But you said it's kind of pronounced without the sound.
Yeah, only because of my New Zealand accent.
Okay.
My mother would say Marmoush, I think.
Okay.
Yeah.
Well, so all right, so I technically wouldn't be incorrect.
No. So the American accent works really well.
Yeah, and I try to I grew up in Texas, so I try to not emphasize my Southern drawl. I do my best. But so you are the founder or co-founder and CEO of Handl Health, correct?
That's right.
Awesome,
yes.
man. Well, I'm excited, and thank you to Shapari, who's off camera, who coordinated this, and she's going to be giving you the stink eye in case you say something you're not supposed to. But we'll be good there. So I want to get to know you real quick. We were kind of chatting off screen before the podcast about obviously your accent and where you're from. And so I'd love to hear your backstory before we get into anything about Handl Health. And I think we're going to have a great conversation about that. But why don't you tell me who you are and how you got here?
Yeah, sure thing. So my name is Ahmed Marmoush, as you said. I am the CEO and co-founder of Handl Health. But before that, I grew up and was part of a family that was from Egypt. We moved to New Zealand in about 1997, so a long time ago.
Okay.
And immigrated because of the beautiful scenery that was there and my family's love for the outdoors. And so I did all of my schooling in New Zealand. I have a sister who's a year and 11 months older than me, but likes to consider herself also my mum.
As they do. That's what older sisters are supposed to do, yeah.
Yes. And it was my mother, my sister, and I that kind of lived in New Zealand. They're still there, actually.
Okay.
And I did all my schooling and went to the University of Auckland, which I know is a great university. And I had a ton of fun, but I studied a Bachelor of Pharmacy there.
Okay, yeah, so you're one of the rare people, because I do talk to a lot of people, obviously, in the insurance business, whether you're a solution provider, a carrier, broker, et cetera. There are very few, I'd say less than 10% of the people I've talked to actually studied anything related to the business. So what drew you to studying pharmacy? Was it pharmacy, or
That's
what was
right.
your technical degree in?
Yeah, so it was a Bachelor of Pharmacy, and I would come out as a pharmacist.
Okay.
And funny story, actually, I come from a family of pharmacists.
Do you really?
So,
Okay.
Yes,
Okay.
yes.
Mom and dad, or grandparents,
Mom,
or
dad,
what? Okay.
both pharmacists. My grandmother on my father's side was also a pharmacist.
So it was a foregone conclusion that you were going to be a pharmacist.
You know
right?
what? Like, so when we were trying to figure out what I wanted to study at university, and my sister at the time wanted to be a vet, but decided she was going to become a pharmacist.
Okay.
And I was toying up between engineering and pharmacy school. Those are my two options. But I was also quite mischievous as a youth.
Were you? Okay. In what way? What way?
I like to have fun, you could say.
Okay.
My teachers sometimes called me disruptive. I just thought they were boring, but hey, I think that's one for debate.
Well, I think, yes, I was somewhat what you would consider a class clown, I think, growing up, but that's a term we would use. And I think that disruption comes from being a little bit bored, being somewhat maybe unchallenged. You know, maybe it's not interesting to you. Maybe the subject matter is somewhat simple, right? Yeah. I presume you're obviously a pretty smart guy. So I think that's just a label that people put on kids because they're not sitting there and just being quiet and listening all the time. So how were you disruptive? Were you a talker or funny guy or what?
I think a bit of everything, honestly. Yeah. So love to talk. And I've always been the sort of person to challenge status quo.
Cool.
My team sometimes gives me a hard time about being counterculture.
Okay.
But I always question things for why they are the way they are. And my teachers didn't necessarily always love that, but my family always encouraged debate in our household. You know, it was always good to discuss things. And coming from an Arab family, things can get heated and we argue, but we do it from a place of love, right? We're loud people, generally speaking. And so I think, you know, coming into New Zealand with that mentality wasn't always seen as in a positive light, sometimes seen as disruptive. And then I was just somebody who loved to joke around.
Yeah, well, I am as well, but I think that probably speaks to why you're an entrepreneur. And I do want to hear how you got, from potentially being a pharmacist or an engineer to what you do now. But you were telling me an interesting story that I have to ask about this. Your sister got married in New Zealand during the pandemic, and you told me kind of the quarantine story and what it was like to travel to New Zealand during that time. So would you mind sharing that with the audience?
Of course, yeah. So, my sister decided, of all times, that she wanted to get married right in the middle of COVID, as my sister does. And so
I'll have to meet the sister. She sounds like an interesting character.
And so I wasn't going to miss that one, obviously. So I made my way over to New Zealand. And when I got there, we were met by the COVID program, which was run by the Army of New Zealand.
Okay.
And we're essentially escorted off the plane into this quarantining process. So
you knew this was all coming, though, right? You were prepared for it, or was it more severe than maybe you expected?
So there was definitely some information online about sort of how it works and what to be aware of, what not to do. But then I think as you go into it, it's a very different experience. Okay. So we were on the plane waiting for the quarantine process to start for about 45 minutes.
Okay.
And then the processing time took about, I think, 2 to 3 hours in total, whereby you sort of line up as cattle and they swab you each one at a time and then make sure so that's your first test.
Okay.
Then they put you on buses and they allocate you to different parts of the country.
Okay.
So I was going into Auckland, but I was sent to Christchurch, which is in the South Island.
Were you traveling solo during the time, or were you with anybody? Okay, you were solo. Okay, so at least that's, because would there be the potential for being split up from loved ones possibly if you traveled together, or no?
I don't think there was, but there were families that were kind of moving everywhere, right? So it wasn't the most convenient experience, but they did do well at keeping it all contained, I think.
Well, you kind of described it as a friendly jail in a sense, right? Because they took you and you had to go basically a hotel room.
That's right.
But then they gave you were describing it because, they gave you an hour of exercise and they gave you food and you get 2 hours of sun. I'm probably exaggerating a bit.
No.
What was the experience like getting through that 2 weeks?
Yeah, so I exercised a lot. I think I came out of the 2-week quarantine more fit than I've probably ever been.
Nice, yeah.
But I can imagine it would be really hard for some people. I mean, you're in your room for most of the day. You get 1 to 2 hours of sort of outside time, assuming you don't have any symptoms.
Yep.
But the people are really friendly, and I think New Zealand has a culture of you do what you need to do for the country.
Okay.
And that's it runs through our rugby team. So the All Blacks is a huge part of our community. But I think I often say the New Zealand way of life and the culture is brought up with huge amounts of camaraderie, being a team player, and just doing the right thing.
Just doing the right thing.
Yeah, and I think that's why New Zealand sort of rallied behind this as an approach.
Yeah, and so wedding go off without a hitch. I got at least close the loop there.
Yeah, wedding was fantastic actually. Had a great time, and it all went really well. So
awesome. Yeah, well, that's cool. It's just a great story, man, and I appreciate you giving me kind of firsthand perspective, because all we really get is either what you see on the news here, and or maybe if you're finding information online, you don't really know exactly how the severity of it. But pretty cool. Thanks for sharing that, man.
Of course.
So I want to now connect the dots again. So your understudy was in pharmacy.
Yeah.
Then you went to graduate school as well, right? So what did you study there?
That's right. So after I finished my Bachelor's of Pharmacy, I worked at a hospital, a tertiary hospital in New Zealand, and I did that for about 4 years. And so I started as a clinical pharmacist and loved it. I was working alongside physicians and nurses in the wards, and I got to experience all types of clinical care.
Okay.
So that was primary care out in the communities, but also hospital settings, so geriatric care, surgery, medicine. And it gave me great exposure to hospital operations and just care delivery, generally speaking. But I was inherently frustrated with what I felt was working in a broken system.
Okay.
So as clinicians, we spent so much of our time doing things that didn't necessarily contribute to patient care. And the system wasn't necessarily designed to keep patients out of hospital or keep patients well and at home. So I would bring up these issues to my seniors and talk about opportunities for improvement, how we could think differently. And ended up actually falling into quality improvement roles first, and then from that moved into project management. And then at that point I noticed, and I was really enjoying that type of work, so I decided it was time to go back to business school and do a postgrad diploma in health. Okay.
So juxtapose, if you will, because you talked about some of the stuff in that particular system you didn't like, maybe it was inefficient, wasn't focused on patient outcomes. Kind of describe for me, if you will, the New Zealand system of healthcare, and then let's talk about how that might kind of measure to the U.S. system.
Sure thing, yeah. So New Zealand operates a tax-funded healthcare system. So basically, as residents of New Zealand, we all pay our taxes. A portion of that is taken and is put into the healthcare system. And what that means is no matter who you are or your financial status, at the point you need healthcare, you will always get it. All right. So in emergency situations, you don't pay anything. For primary care services, so seeing a family doctor, you would pay a co-payment, but that was determined based on your ability to pay.
Okay. So theoretically, if you didn't have the ability to pay, would it be waived in that situation?
Exactly.
Okay.
And there were programs to support people in that regard. And that model was actually carried through our social system and justice system as well. So using taxes to cover those you know, basic human needs as such as part of
So give me a sense of what would a tax rate then look like? Because that is always an argument in the U.S. system, is if we publicize or turn it into a public health system instead, the cost, right? And that means our taxes would obviously go up to support that. So what was maybe the marginally the highest tax rate in order to support
So highest tax rate was 32%.
Okay.
And I think it still is, but I might have to refresh my memory.
Okay, so less than I would have anticipated. Okay.
Yeah, so the UK is much higher, sitting in the 42, 45%, I think. But they have healthcare that is free at the point of access, no matter where you are in sort of your care journey. So that might be primary care, hospital services, it didn't really matter.
And does New Zealand have any sort of tiered system where you can buy up into private coverage or access or anything like that?
Yes.
Okay.
Yes. So there is the option to buy private insurance to supplement the public healthcare services that you receive. And really, I think the reason you would do that was because you either wanted to increase the speed in which you get care. That's sort of a big thing, especially around cancer care or surgery. And also the other thing is just having the option to go to places that you may not otherwise have to.
Well, and that's what the debate is often between the Canadian healthcare system and the U.S. Obviously, proximity makes it easy for them to come over and seek care in the U.S. Often that is one of those counterpoints. It's like, yes, they have a more of a public model, but oftentimes people, because of the wait times to get in to see a physician or to get a procedure, they will come to the U.S. in order to pay cash for that procedure because they can get it right away. So did you ever see anything like that in New Zealand, or did that public-private style model account for that? This podcast is brought to you by True Captive Insurance, a premier medical stop-loss captive for employer groups ranging from 25 to 1,000 employees. True Captive believes in healthcare that is personal and insurance that isn't complicated. That's why they take a white glove approach, making it easy for employer groups to transition into a program built specifically for them. Check them out at truecaptive.com.
I think we definitely did see that. So the way that a public health system or publicly funded health system thinks or operates is it always comes down to outcomes. So they look across a number of outcome measures in terms of population health and mortality. And that's how you make decisions when you have a finite envelope of cash. And so what I mean by that is those who are most sick will always get care first. So cancer treatments was a priority. Surgery that was needed was a priority. Emergency medicine was a priority. And then after that, your access to care determined on your need. And so longer wait times were determined by how much you needed that service.
I see.
And that is just an inherent, I think, challenge that exists for publicly or tax-funded healthcare systems.
Yeah. So, I mean, I always am cautious never to paint an either or better or worse. I think in any system, because they're infinitely complex, there's going to be some things that are better and some things that are worse. And also that's a subjective measurement as well. So during that time while you were there, obviously you said you went back to business school and got a postgraduate degree in business. What was it? Did you want to lean in more to the administrative side of things? Is that what you wanted to do? Okay, so tell me about that time then.
Yeah, sure. So I was actually still working as a pharmacist, and I was part of a campaign there which was called the Bed Reduction Campaign as part of the hospital I was with. And that was focused on shifting patients out of hospitals and into lower cost and higher value settings, such as primary care settings and community-based healthcare services. And as part of that, I was also doing my postgraduate diploma, which was covering a variety of things from just core business papers that you needed to have, in addition to population health and healthcare administration, which was what is healthcare economics and how do you think about some of the market failures that exist in healthcare, because it is one of those services that people need without necessarily having a choice.
Yes, yeah, absolutely.
And that is some of the greatest sort of arguments and debates about the importance of having, at least in part, a tax-funded component for those that simply can't pay.
Yeah. So being the disruptor that you are, what was it about the system that you maybe disagreed with or you thought was inefficient and you wanted to solve for while you were there?
Honestly, it came down to bureaucracy for me.
Okay.
And also that the way in which hospitals were funded in New Zealand and how the cash flowed. And actually, since then, they've restructured the entire New Zealand health system. And
did you have any part in
no,
that?
I didn't actually. No. But it was often that the cash or the funding sat in the hospitals just by virtue of where that care was centralized around the physicians that worked there, etc. But the bureaucracy piece was that patients would get kept in hospitals and not necessarily pushed out into the community setting where we knew that they had better chances of recovering, less risk of infection. And so as I was experiencing that on a patient-by-patient level, it might be that the patient can get their medicines on time or couldn't get discharged. And that, at a small scale was manageable. But when you start to add that into thousands, hundreds of thousands, millions, you can see the impact not only on the bottom line of hospitals in terms of it costing the system more, but also on the patient and their outcomes.
Well, and that's what you would, when you talk about the American mentality of things. And then I do want to fast forward. Obviously, we're going to spend a significant portion on Handl Health, and I really want to talk about that deeply. But the American mentality is often that, anything that you sort of offload to the government or you have the government take over, that bureaucracy that you described, those inefficiencies, the redundancy, the length of time it takes to do anything in our government sometimes is pretty egregious. And so that's often where people start screaming, right? Is it's going to be very, very expensive, or that's the presumption. And probably outcomes, quality of care, the bureaucracy, all those things I just described get now layered into the system that already has some of that, but might amplify some of those disadvantages. So before we get into that, which I know we could spend the whole episode talking about that, I want to move forward in your timeline, right? So you were, how long were you in New Zealand doing this postgraduate work and the work that you were doing before you moved?
So, good question. I was probably there for about 20 years before leaving.
Okay.
That's not true. I was let me calculate. Yeah.
So the numbers, don't worry. Nobody's going to check.
Okay, no worries. Yeah. So I must have left uni when I was about 22, and I left New Zealand when I was about 26. Okay. So I did that for about 4.5 years.
So where did you go from there?
From there, I moved to the UK, actually. And I had a brief stint in Australia just before the UK, which was still working with the same company. So at the time after business school, I actually ended up moving into consulting. Okay. So it was my way of being able to make change at a greater scale. So I worked for a boutique health consultancy initially that was led by the former Director General of Health in New Zealand, which was basically the CEO of healthcare in New Zealand.
I see.
And that just gave me incredible exposure,
I imagine,
to how an executive thinks about delivering strategies for a tax-funded system, how you consider outcomes and you make trade-offs when making decisions around funding, and also how you lead and create exceptional performing teams at that scale. And then from there, we were actually acquired as a firm by EY at the time in New Zealand. I saw
that on the resume. So then did you continue kind of in a similar role once the acquisition happened?
Yes. Okay. Yeah. So just part of a much bigger firm at that point. And because I had an interest in traveling and seeing the world, that company gave me the opportunity to do that. So with EY, I did a project in Australia. I was actually in northern Queensland in a town called Rockhampton, working with a health system up there. And that was just so eye-opening.
Was it more of a rural setting then than
much
you were
more
accustomed
of a
to?
rural setting, that's right, yes. And they're known for their cattle and their beef. And so it was a fantastic opportunity just to interact with a very different population, understand their health needs and how that was different to ours, but also just enjoy Australia and the beauty of the country.
Well, it's just hearing you describe kind of the stops along your journey. I mean, you've been exposed to a lot of variety, right, of healthcare structures. You've obviously got to see it from a perspective of the publicly funded system, and then obviously we'll talk about your perspective on the private system, and then working hand in hand with, like you said, the CEO of healthcare, and then in a consulting firm. I mean, feels like every step in your journey has probably prepared you for your entrepreneurship, which is that's why I want to flash forward now, because I think it's really going to be interesting to dig into this. And I think it's timely, right? We were talking with the CAA as well. So when did you take the step to become an entrepreneur?
Sure. Yes. So I took the step of becoming an entrepreneur about 2 years ago, I would say. Initially started as an idea and started doing some of the work while I was still working full time. And then sort of took the plunge recently, actually, I think it was June of this year, where I went full time into Handl Health.
So how did you get obsessed with this idea?
I've always had a dream. Funnily enough, always had a dream to start a business in the US. I think.
Really? Yeah. I mean, how early can you remember?
I think when I first, I've always had the bug for entrepreneurship. When I was going through school, university, I would always come up with different ideas. I tried a few different business ideas when I was still in New Zealand, and we actually launched one in New Zealand, which was a great amount of fun and taught me a whole heap. But when I was thinking about starting a business in healthcare, you know that the US is privately funded. There's a ton of capital that goes into it, and that sparks innovation, and you can't deny that.
Absolutely.
And so that was sort of seen as the place to be to start a business.
So did you once you knew you were going to go on this path, decide I've got to get to the U.S. Or how, what came first, the chicken or the egg?
Yeah. So you know what? I think honestly, as life happens, as I'm sure you also know, none of it was necessarily overly planned. But I knew that I wanted to get there eventually. And it just so happened that I had the right opportunities.
Well, I'd say, yeah, I know exactly what you mean with nothing is literally why we're sitting on the couch in this angle and not over on the black wall is Nathan one day goes, hey, why don't we try it over here? I'm like, okay, cool. And it became the setup for the next 20 episodes, and I love it. So sometimes ideas just come out of nowhere and you go with them and there's not a lot of preparation and they end up turning out great. So Handl.
Yes.
Let's move into that. Let's talk about Handl Health, what it is, what you do. But this idea that you had, that you wanted to tackle some problem in the U.S. system, did you know what that problem even was at the time?
No,
okay.
No. So I came over into the US and worked in digital health with EY at the time. And my job was primarily to build digital health products and businesses for national payers and providers.
Okay.
And that gave me firsthand experience into some of the challenges that our clients were facing around interoperability, around creating connected experiences for their patients or members. And in terms of how that would then relay into the patient experience. And as I'm a huge proponent of, humans are incredible creatures. We all are. We're given the right tools and technology, we can do some amazing things. And healthcare in the US seems inherently complex and is. And somebody who has understood healthcare, I would say in a fair amount of detail, I really struggled when I first came here to wrap my head around the insurance model. And then had a delightful experience when I first went to interact with the health system, which really sparked the idea of, hey, this must change, because if I'm going through this, it means...
Man, this is almost a universal through line with entrepreneurs that I've talked to. It's like, I had a problem.
Yeah.
I go, wow, that problem was really bad. Maybe other people have this problem. And oh, by the way, maybe there's a market for solving this problem. So exactly. What was your particular problem, or what was the eye-opening experience for you?
Yeah. So it was my first encounter with the US health system. Somebody said to me, hey, you get annual physicals free on your insurance, so you should really make the most of it. I was like, okay, hey, I haven't had this opportunity before. So why don't I go and try it? I went there and ended up having a diagnostic blood test, which I didn't know at the time. The doctor didn't say anything to me in the room. About a month and a half later, I got a bill for $800 for a service that I thought was going to be entirely free. So I called them and I was like, hey, why have I been charged for an annual physical and why is it $800? And they sent me an itemized bill. So I responded and saying, I'm just simply not going to pay for this because you didn't tell me beforehand. And as a consumer, I wasn't prepared or understood what questions I was and was not supposed to ask in that setting. So at the time they said, okay, let's waive this by 50%. And if you pay today, it'll be done. And I thought to myself, wow, the US healthcare system, it's seen globally as a place where you can get the most innovative, best clinical medicine in terms of quality, but you do have to pay for it. But at the same time, when you look under the hood, somebody once called it the bowels of the healthcare system.
So that's a good way to put it.
You're right. How finances flow through the system and how revenue cycle happens is truly backwards. It actually reminds me of when I'm in Egypt seeing family and we go to the local markets and we're bartering or negotiating down different prices. That's what it felt like when I was speaking to this national healthcare system about my bill. And how could that be?
And literally you was like, I don't want to pay it. And they say, okay, well, we'll cut it in half. Will you pay that? Because all they really want is your money, right? And they want it as quickly as possible, right? Because they know the longer it drags out, the less likely they are going to get it. Even if they send it to collections, what are they going to collect? $50 or $100 on that $800 bill? But that's into the calculus of their model itself, right? Exactly. They know a certain percentage of people will just pay it blindly. A smaller subset will argue a little bit, but pay less. And then a few of them might not actually pay, but that's built into the charge itself,
exactly.
Right? Yeah, well, that's probably one of the most egregious parts of our system. I would agree with you. Literally, the episode I just released this week, the gal Sarah over at Predictable exact same story. She got a $400 bill because there was a vitamin D test that she thought, oh, I get preventative care and it's free on my HSA. And yeah, but they charge you $400 for this vitamin D test that wasn't covered and nobody told her about it. So part of me thinks, oh, that's terrible. But another part of me thinks, oh, let's keep doing that so we get entrepreneurs like you that shout at the rooftops and build businesses around it. So you obviously had that initial experience and it was bad. At what point did you recognize, oh, okay, I can actually do something about this, or I want to do something about this?
Yeah.
This podcast is sponsored by PlanSite. PlanSite is a technology for employee benefits brokers to more efficiently manage their RFP process for any group size, all funding types, and over 20 benefit lines and point solutions. PlanSite is the only end-to-end RFP technology on the market today. Let's modernize your RFP process together. Check us out at plansite.com.
So as you go about life, when something happens to you that's negative, sometimes you'll talk to friends about it and complain at times. And so I was doing exactly that. And there was something I noticed that every time I told somebody about it, they would respond with a story. And to this day, we're speaking with venture capital at the moment. VCs are relaying the same sort of anecdote. They're like, oh, I've had this experience myself. And so we noticed early on that we started to see a trend that consumers across the US were feeling this pain the same way I had and the same way my co-founder had. And so what we decided to do was set up a research lab. We had one of our team members at the time had a master's in design and was a huge proponent of user experience. And so she suggested that we set up a research lab and do user experience to understand the true feelings of the consumers we wanted to serve around healthcare. And so we did that. We launched a survey and we had an overwhelming response. I think we had 500 or over 500 responses in less than 60 days.
No kidding.
And the areas of focus we had were, what are the pain points you experience when interacting with the healthcare system? What are the parts that you're most concerned about? What are the feelings that you have towards the healthcare system? And there was a ton of distrust. There was a ton of being overwhelmed and confused. But the two things that people talked about sort of unanimously was the desire to understand the cost of healthcare before they received it. And the second thing was understanding or simplifying how the billing process happened.
Yeah, the billing. So if you don't know him already, I'll make sure to connect you afterwards. Marshall Allen, have you read Never Pay the First Bill?
Yes,
okay.
yes.
Everything you're describing, that's basically what his 10-year investigative journey was about, was this egregious billing practices and all these stories of collecting just horror stories from people being somewhat exploited I think is the word he used in the system. And so I have no doubt that there are probably an infinite number of stories that you can tell there. So setting up Handl Health, I think it's a perfect time. Let's transition into what is Handl Health? Why don't we just start right there?
Yeah, sure thing. So, at our core, we're a consumer-facing application that insurers use to help them comply with the healthcare price transparency legislation. And that's through digitizing how their members shop for healthcare, manage their appointments, and also manage their finances.
And was this before or as a result of the CAA? Because your timing is obviously good, and I don't think that's an accident.
Yeah. So believe it or not, so the idea and the work we had came before the CAA.
Okay.
And so we were actually successful with a government grant from SBIR to understand how healthcare price transparency legislation would impact the American consumer when hospital price transparency first came out.
Okay.
And then we saw this tidal wave of legislation follow hospital price transparency that just made us think, wow, there's not only government momentum around this and legislative momentum, but we're hearing directly from consumers and employers about their frustrations around healthcare. So it was almost serendipitous, you could say. We had a feeling, and then it all kind of came out to bear. And I think the timing for us just happened to be really good. Okay,
so what you're doing, and maybe you obviously will add the gaps of what my description is, but you guys are intaking massive amounts of data. There was a number, I think, in an article that Shapari sent me that was like, how many terabytes, or I don't even know the term. It got so big.
About 1,000 terabytes of data is what we're estimating that we published.
So give me some context. 1,000 terabytes. How much information is that?
Yeah. So it's a really good question. Because I'm non-technical, I can only describe it to you in very
Let's put it in layman's terms, okay?
So usually a file is about gigabytes or megabytes. Then you have a whole heap of bytes in between a gigabyte and a terabyte. But what I can tell you is we're talking hundreds of billions and trillions of rows of pricing data being published. So to the extent that a lot of our business in the early stages was focused on helping health plans with trying to produce the machine-readable files that were required under the transparency.
Well, and that's been the obvious thing that people see as a response to the hospitals releasing their data and being in compliance is like they release these files that are unreadable to most systems, right? So talk to me about the interpretation of data, normalizing and actually being able to make sense for a user to digest it.
Yeah, sure thing. So, I think the CMS learnt from hospital price transparency. They didn't have a schema put in place. And so hospitals were publishing their data in all different types of formats, which meant mining that was actually a very manual and challenging process. So they went ahead and put a schema in place for health plans, so employers, self-funded employers, and insurance carriers, and that was very clear as to what they needed to produce. But the implication of that was they were creating these huge files that couldn't be digested by normal machines. And so what we've done is we've built technology that automates the extraction of these machine-readable files and cleans it and organizes it in a way that makes it digestible by applications. And that's sort of the big value proposition or our secret sauce as such.
So by applications, so then is there a handoff from your system to others that now then interpret and are customer facing, or how does that work?
Yeah, so what we wanted to do was build an engine that would create what we call as these endpoints, which is basically where we can surface data. And what that engine does is not only does it mine information, but then what we do is we bring additional data sources into it. So we look at quality data in particular, and then look at publicly available additional pricing data sets to allow us to start to benchmark and make apples to apples comparisons to understand value. And that's ultimately what we were looking at, is how do we start to interpret what value looks like for employers, insurance, but also most importantly, consumers. And then what we do with that is we surface those endpoints and it's actually digestible or pushed through our own application, which we license out to insurance carriers and employers, but we also have it available so that should you have an application and you want to use this data, you can license that from us too.
Well, so then talk to me the end user, right? The interface itself. How do I, as a member on a plan or an employer, use that data then to go shop? Or what are the things that I'm doing with that information once I get it?
Yeah, so as a member, your employer or insurance carrier would have licensed and white labeled our application. And so you would, the use case as such would be you'd be looking for healthcare or had some sort of need that you were coming to seek healthcare services for. And so you'd log on to Handl Health as you would with any of your email or anything else that you would access, and you would be able to shop for healthcare as you would for any other part of your lives today. So you would type in a service.
Give me a common example. Give me something that's pretty straightforward that I'd be able to shop.
Sure. So an MRI is always a really good example that you could use, but any sort of diagnostic, whether it's a blood test, and even if you were shopping around to understand the cost of what would it be to, have a baby in the US, you'd be able to understand that cost with our tool. So it helps not only with an immediate need, but also planning for future scenarios as well. And you would type in that service and you would include some of your preferences. So what we've built in the background are integration points so we can collect all of the accumulators without you having to know what your deductible and out-of-pocket max is, etc. And then your zip code and radius and any preferences you have around the type of provider you want to see by gender or specialty. And we would return results for you on those grounds. And we would prioritize them based on your preferences, whether it's location, whether you have some facilities that you prefer to go to, or even if you are interested in price and want to know like the cheapest versus the most expensive.
But you said you also layer in quality measures of the doctors, right? And outcomes.
That's right.
So how do you put that? I wouldn't even call it a subjective layer, but if I'm only price sensitive, that's one thing. But if I also want to pick the best doctor that might also provide great value, how do you pull in that data and what does that look like?
Yeah. So as part of the search experience, you have the ability to also understand the quality of a provider and also the quality of a facility. And so you would be able to make that determination when you're searching and shopping around, and you'd be able to, for example, filter by 5-star ratings or 3-star, however you want to look at it. And then you're able to actually dive in a little deeper and understand, okay, so what's the rationale for the rating, which is not ratings we create, but ratings that we bring in from publicly.
Is that like Healthcare Blue Book, or are there multiple sources?
Medicare is where we've started, and then we work with another third-party vendor that's doing a very comprehensive analysis of different scores around appropriateness, effectiveness, of care, and really trying to determine like a value-based score.
Well, I'm glad you mentioned appropriateness, because I know that's especially here in Texas, and common surgeries like spine surgeries and things like that. Like, how many are actually appropriate, or how many are they just surgeons convincing people to get back surgery, right? And that is the big debate that I've heard waged here. So you add appropriateness into it, and then who is maybe an appropriate, using that word again, but who is an appropriate employer, size, fully insured, self-funded? Give me some of the dynamics of a plan that would benefit from this.
Yeah, so we're sort of targeting the 50 to 4,000 range, which I know is huge, but we can serve any self-funded employer who wants to offer a care management tool for their employees that is digital friendly, but we also have an SMS and digital concierge function. And so we would be part of the suite of technology that they have to administer their health benefits.
Okay.
And an employer that's, for us, it's about being a progressive employer that's interested in exploring new and innovative ways to do steerage, but also to trial different models of care. So, for example, one of the things we say is our secret sauce is our ability to not only work with health plans, but to bring in providers. And we can use the legislation to do that, because providers also have compliance requirements through good faith estimates and other things like that.
Well, can we talk about the legislative piece? Because sure. I think I was telling you the episode, I know this will be in the future, but the episode I'm releasing next week, at least in the actual world, is about the CAA.
Yeah.
So kind of talk to me about the opportunity that was created out of there. And if you can, maybe the broker audience is mostly listening to this, if you can talk about things that they should think about in order to make sure their employers are compliant with the CAA.
Definitely. Yeah, of course. So I describe the price transparency landscape as having 3 key pieces of legislation. Hospital price transparency, which I think we're all familiar with. And then under the Consolidated Appropriations Act, there was the No Surprises Act, but there was also transparency and coverage. So the No Surprises Act, I think we all know about the banning of surprise billings and
balance bills,
all of that stuff. But the one that I think is worthwhile flagging is the good faith estimate requirements, and how that potentially might transfer into advanced DOBs into health plans. So as benefits brokers are thinking about what 2024 looks like, where there's an RFI out from the CMS at the moment collecting sort of feedback on their proposal for the advanced DOB. Okay. And what that would essentially mean is for any patient who is covered under insurance, they would have the ability to request a quote of their services. And that would have to be not only from the provider that they're seeing, but for their total cost of care. So if I was going through a maternity pathway, it wouldn't only be for my prenatal appointments, but it would also be for my labor and any postnatal care, which is significant. Significant in a number of ways. Not only is it shifting the revenue cycle function from 30 to 120 days after care is received to now before an appointment is even administered, but it is also getting us to think as a healthcare system differently about how we collaborate between providers and also insurers, because we're condensing the amount of time in which that process happens. So really, a provider who's an obstetrician might have to work with a number of other providers to agree what that cost of care for a care journey would look like, and then send that over to an insurance carrier to sort of give that the benefit.
Well, and so it's going to put in the onus on the provider now to say, what does it actually cost you? Obviously, nobody wants them to work for free nor lose money, but I think the argument is always the fairness in which they make money or they profit. And obviously with us having in the U.S. different networks, different insurance carriers that own these networks and discounts and all of this sort of murkiness that happens within that arrangement, it's the egregious disparity between the same procedure depending on which logo you have on your
Exactly.
ID card. So I am all about what the CAA is intending to do. I also believe that anytime regulation comes down, there's lots of unintended consequences, which we shall see. But you were talking to me, I think off camera beforehand, that one of the mechanisms to enforce this is fines, right?
Yes.
So can you give me a sense of some of the fines that people expect to see?
Yeah, sure thing. And so we covered off No Surprises Act, just quickly on transparency and coverage, because I think the fines are really strong relating to this. So transparency and coverage requirements for all the brokers that are listening out there, their employers who are self-funded are required legally to publish the prices that they have negotiated with providers in their network.
I like that. Yep.
In addition to the out-of-network claims that they have had in the past 90 days and within a 6-month period. So that's one part of the legislation. The second part is actually the shopping tool requirement. So come January 1, 2023, employers and insurance carriers have to offer their members a consumer-facing shopping tool that is accessed from the web. And that would allow them to compare and contrast the cost of services to be able to make a cost-based determination as to where they should go. Failing to comply with either of those components risks fines of up to $100 per member per day.
Yeah.
So we're talking huge fines relative to what we had for hospital price transparency, which was only up to $5,000 per hospital.
So $100 per member per day. And is that total membership of the plan, right? Okay,
That's right.
So $100,000 a day if you have 1,000 members on your plan, and obviously there's much bigger employers than that. And I was telling you, I presume there'll be some examples that are made just to kind of show, hey, little guy, little employer over here, make sure you're compliant. But I think I mentioned earlier that now the onus might be on the providers to establish the appropriateness of pricing. That's one thing. The other thing is now the fiduciary responsibility of the employer to be compliant, right? So they're going, how do I even make sure I'm in compliant? And you said there's a good faith element to this, right? That they're making steps towards being compliant. They don't necessarily have to be compliant on day one, or at least that's what I've heard. But the shopping tool is really where you guys fit, right?
That's right.
It's the shopping tool. And I'm sure there's others out there. But now I'm a member. Now I have the ability at the touch of a button or a few buttons to predict perhaps the cost.
Yeah.
How do you make it intuitive enough for somebody that doesn't often interact with the healthcare system to find what they need and then have the responses be simple enough for them to make an informed choice? Because I'm sure that's far easier said than done.
We're on a mission to partner with the most innovative companies in America to fix health benefits, one plan at a time. NavMD has created a blueprint that delivers world-class benefits to 155 million Americans. Better benefits starts with data intelligence. Our platform is empowering the next generation of advisors to zero in on opportunities to optimize the plan, build the right team, implement proven strategies and solutions. Join us on our journey to revolutionize health benefits. Let NavMD put you a step ahead.
I mean, that's a great question and something that we continue to work on, actually. So really, we think of engagement as one of the most important metrics that we measure in order to how to sort of improve our service to consumers. And the big thing for us is, if you're not digitally savvy, you shouldn't have to use an application. So we're thinking and exploring different ways to make it so that you can search by text and receive responses by text.
Yeah.
The second thing is, people don't think about accessing healthcare services and think, oh, I need to get an appointment, and therefore I'm going to search, a doctor's appointment to understand the cost, or I need an MRI, and then I will search for an MRI. What they usually search for is specialty or provider, and they typically ask for their friends and family for feedback.
Yes.
And so what we're focused on is how to make that search experience intuitive. So when you think, oh, I need an appointment, what are the most important things for you as a consumer to be searching for? And allowing that flexibility. If you want to search for a service, if you want to search for a provider, if you want to search by a hospital, you can do that. So the search is dynamic enough to accommodate that. The second thing is where we engage. So not only are we looking to engage with you at the point in time you're first making that search, but also if you've received a referral from your physician, how can we work with your employers and your insurance carriers to identify through prior authorization or similar that you've been searching and then reach out to you proactively. So really when we talk about our secret sauce as such, yes, it's the data, but for us, it's about shifting the way steerage is done. And it's about empowering consumers to understand how they should choose or where they should go to access healthcare through the use of data and us understanding who they are to make recommendations based on their needs.
Yeah, and it's almost funny. We now have to retrain the population to shop for healthcare just like they shop like everything else, because I'm in the system and I still don't go through a sophisticated process for choice. Most of the time, like you said, it's a friend or a referral. I know enough to hit the pause button and not just show up at an MRI location without at least having a sense of what it might cost, but most people don't. Yeah. However, if you're shopping for clothes online, you're shopping for a car, you're going to spend hours and hours often doing research before you make that purchase. And then we just blindly often consume healthcare without any decision making at all. Very so true. Like I'm saying, you kind of have to retrain people like, no, you can do the same thing for healthcare. The problem has always been it's been so difficult in order for the average person to be able to do that. That's right. Which is where insert Handl here. So you told me 50 to 4,000 in mostly self-funded employers. How or does this not work on fully insured groups and small groups?
So it does work on fully insured groups. You know, we're actually speaking with some insurance carriers at the moment about how they could roll out our tool to improve their consumer experience. The challenge is for us, the way we see the most value. So we don't want to be a consumer-facing tool and that's sort of all you get. For us, it's about outcomes and how you shift the way in which you manage your healthcare budget, not only to give your members or your employees more money back in their pocket, but for you to reduce your total cost of care as well. And to truly be able to do that, we need alignment of incentives. And that's why the self-funded employer space makes a ton of sense for us, because we know that there is that aligned incentive model.
Absolutely. I like that. So why don't we zoom back out? Because I don't think, the one thing I really did want to address with you, which I think we've kind of covered here and there, is the juxtaposition of the public and private model. Yes. So now that you're here in it and you're solving problems in the United States, in our private system, weigh kind of the pros and cons of what you see having lived in some other systems as well.
Yeah, sure thing. So I think, I will draw parallels between, the three systems that I've lived and worked in heavily, which is the US, the United Kingdom, and New Zealand. And what I would say is there are a few key points to note. The first one is the United States size. So we're talking 300 million, I think, is the population here.
325, 50. Yeah. I mean, it's a huge number.
So there is the size of the country simply does not make it a good candidate for a fully publicly funded or tax funded system. Okay. For a number of reasons, bureaucracy being sort of the big one. But what I would say is also the private public mix allows for this ability to use legislation to sort of guard how a healthcare system is delivered, but then also to use the incentives around a privatized model to spur innovation and to create competition, which drives, I think, better quality and outcomes ultimately. The challenge for me that exists in the US healthcare system is around universal access. And so what I mean by that is the beauty of tax-funded systems is your ability to access healthcare isn't determined by how much you have to pay or your financial means to be able to afford care. In the United States, I think there are certainly public or government-funded programs to account for those that can't afford, but there is still a large group of the population who may not be able to afford the best care and therefore can't access healthcare. And so what's the ramifications? Well, we know that the stats are pretty alarming. I think it's 1 in 5 families don't have the savings in their bank accounts today to afford their total out-of-pocket costs. And so that's why you see some of the stats at a population level where the US model doesn't perform as well as other countries, which comes down to things like mortality rates, which is driven primarily due to access. And so the pros of the system, I think, really are about how you spur innovation. I mean, there's a reason why I came to the US to start a business, because I know for a fact, and I think it's globally known, that innovation is spurred by capital, which is spurred by private markets, which creates competition. And that is a very healthy environment to live in. But because of market failure with healthcare, which is to say, as consumers, we need healthcare and don't necessarily have the ability to choose when we need it, there needs to be a safety net, which sort of catches those people.
Well, and I think you kind of hit the nail on the head there, and brilliantly put. I didn't want to interrupt you because that'll probably be a clip. So what I would say, though, is the middle ground is really where the problem lives, right? You mentioned that there's a safety net for the people that functionally cannot afford it and live below certain income levels. And then the other end of the spectrum is people that absolutely can afford any type of care, and the premiums and the out-of-pocket expenses aren't even a factor in their decision-making process. Most people, though, live in that middle ground where they're functionally uninsured or underinsured. You mentioned 1 in 5 can't afford their out-of-pocket expenses. So some of us will go try to solve for that. Other people will just say, hey, well, let's layer in a cheaper way for you to borrow money for that gap, or let's do an HSA. And, none of them are exactly solving the problem. They're just slapping a Band-Aid on that problem. But like you said, most people, I don't know what percentage of Americans, I'd be speculating, that would live in that middle ground where, yes, I have insurance, but I'm probably delaying care, or I'm not getting the care that's appropriate for me because I can't afford $500 or I can't afford $1,000. So I might actually be less healthy than both ends of both extreme ends of the spectrum, because I just didn't get the care I needed because I needed to go pay for college for my kid, or I needed to go pay for something else. And this just got set by the wayside. My own health got set by the wayside. And that is frustrating for me. And that is where I do believe our system fails.
Yes, and I would agree with that. I think where the US excels is the ability to provide individual choice, right? So in New Zealand, for example, you cannot choose the specialist by name. You choose, if you need to see a specialist, you will be allocated to a specialty group.
Okay.
And the person that has the fastest availability will see you. Here you have the ability to choose a provider by name. And that is one of the luxuries of having the system we do. But you're 100% right. For those that sit, the majority of Americans who sit in that group or bracket that we described, they're the ones that I think suffer from the system that exists. And they're also our target market.
Yeah.
They're the people that we're ultimately focused on improving access and affordability.
Well, and that's like you said, though, the model then allows for the opportunity itself to exist to solve that problem. I always talked about this big picture, and I think we'll zoom out to kind of close the show out in the big picture of healthcare. But it's that problem is so infinite, or let's say the number of problems are so vast that there'll never not be an opportunity to solve one of them or solve it at a micro level. But the macro level, it's too complex to just paint a brush and now we've solved every problem, which is where entrepreneurs come in, where we collectively have to decide what things do well and what things don't. And then hopefully over time, we're at least steering the ship in the right direction, but it's going to take a very long time to get there. Yeah. So why don't we do this? Let's land the plane a little bit. Let's zoom back out for big picture.
Yeah.
Handl Health, in big picture, maybe future state, the next few years, what does that look like for your company? And maybe what problems are you already thinking about solving down the road?
Sure thing. So I think in the short to medium term, our focus is on legislation, helping health plans and providers with complying with the legislation. And that includes our consumer-facing tools, it includes our data solutions that we have. But we're focused on health plans today. We plan on moving into the provider space in the next 2 to 3 years. And our objective really is to try and cover the landscape. Today, many vendors will work with health plans or with providers. We think the compliance legislation gives us the opportunity to work with both and presents a very different picture in terms of how you think about care models and also steerage for the future. If I think 7 to 10 years from now, obviously I'm a huge proponent of the price transparency legislation, but I think what it allows us to do and what we're actively focused on is how we can use this data to create a new type of or a new model of insurance moving forward. We will never be an insurance provider. We have no plans to compete with the insurance landscape that exists today. But we do see ourselves being the platform that enables on-demand insurance in the future. And what I mean by that is, think about the way we handle insurance today. We go and we purchase a fixed plan that has a certain number of benefits, and we have no choice on how that is designed. Mm-hmm. But actually the price transparency legislation, and sorry, before I jump into that, one of the biggest drivers of that is how networks are negotiated today. So network is king, and that determines where you can go and how you choose services. But what does the price transparency legislation enable at its core? What it does is it enables us as consumers, as businesses, to be able to understand the complete network market down to how each service is negotiated depending on the different contracts or networks that are available. Yeah. So if that is the case, what's stopping an employer from making their own plan design because they have full access as to every negotiated rate? And I believe that the market will set the prices moving forward, and we'll see huge normalization around the cost of services. And that allows people like you and I to say, okay, so I want reinsurance in case there is something that's going to happen to me that I can't control. But actually for the other parts, there's a primary care network that I really like in this area that I live, and I enjoy homeopathy or different types of services, which I would like to have insured. So we will get to see these new types of insurance models that are custom and designed to our personal needs, which is where I really see the future going.
Well, I like that too. And I really do think you mentioned normalization of the pricing across networks. My hope is the network as we know it sort of dissolves. And I know there's a lot of power and a lot of money behind that not happening. But if transparency were to do anything, it is to expose that disparity that I was describing earlier between the exact same service, the exact same location, but different payer means different price, yes, which is egregious in my opinion. Agreed. That's a big failure. So my hope is that the idea of a network in general sort of goes by the wayside. We'll see what happens there. Yeah. But what about kind of closing thoughts, right? We've covered a lot, man. And this is one of my favorite episodes in a very long time, and I sincerely mean that.
Thank you.
But what would you leave somebody that's been listening for the hour plus that we've had here, kind of closing thoughts or what you want the audience to be thinking about as they move forward?
Certainly. I think, I've been in the US for about 3.5 years. I would continue to encourage Americans to push and demand more of the healthcare system here. You don't have to settle with status quo. Actually, there are people like myself and many other incredible entrepreneurs out there that are trying to solve some of the systemic issues that exist. For my broker colleagues out there, I would say don't look at the healthcare price transparency legislation as something that is daunting or a requirement that you have to deal with. I would see it as an opportunity to create new types of plans and empower consumers to make better choices in the future.
Yeah. Well, very well said. So I know this was your very first podcast as well. So congratulations. You did a fantastic job. Thank you again, Shapari, for hooking this up. But it's been a pleasure, man. I really appreciate you telling your story as well as Handl's story. And I'm sure we'll be doing this again soon.
Thank you so much. Thank you for having me.
My pleasure, man. True Captive believes in healthcare that is personal and insurance that isn't complicated. Check them out at truecaptive.com.